I would, over the next 15 minutes, talk about giant cell tumors of the spine. What is most important to understand is that giant cell tumor itself is a rare tumor, and in the spine, it is still rarer. So we are talking about a tumor which is just 0.04% of all the bone tumors that occurs. But even though it is rare, it is one of the causes for a lot of morbidity and mortality if it is not actually treated properly. So I will just talk of some principles that we need to follow whenever we see a tumor. The first principle is we need to know that it is the same tumor like what occurs in the long bones, that it is benign but can be very locally aggressive and sometimes metastasize also. So the principles of treatment are the same, but the challenges actually become more difficult and much different because of the exotic location. Now, this is what is Enigma's principle. So when you have a tumor like this, if you want to do an intralesional tumor, then you do an en bloc excision within the tumor. Now, that is the maximum that you can do when you're talking about the spine. If you are talking about a radicular en bloc excision, then you have to excise the whole compartment, and that is possible in a long bone. But if you talk about, see, for example, here you are seeing a giant cell tumor that was filled with cement, but you can see that there is a local recurrence, and then it is possible for you to completely radically excise it and then put in a prosthesis. But how do you do the same when there is a tumor in the spine? You can see it transgresses all the other compartments. And when you need to do a radical excision, you're actually talking about a tumor which has actually occupied the epidural space and also infiltrated the dura and many of the vessels, and it's not practically possible for you to do a radical excision. So the first principle is that we have to realize that the first surgery is the best surgery, and there is rarely a need for hurried or unplanned surgeries. Everything you do in the first surgery, you have to plan and execute it to perfection so that you get the best results possible. Now, you also need to know that the surgeon is not the most important part of the whole treatment. If you look at the management, it is actually multidisciplinary. You need to arrive at a good diagnosis. You need to stage the tumor. You need to have a perfect tissue diagnosis. You need help from the radiologist for preoperative embolization. Sometimes adjuvant therapy is required. And you see, you have a lot of things to do before you can go on to excise and reconstruct. So surgery is an important but a small step in the overall management. And sooner a surgeon realizes this, it's good for his patient. The second important thing is there is no clinical or radiological feature that is exclusively diagnostic of GCT or judge about its clinical behavior. This is very important. So if you look at the clinical presentation, Dr. Rajasekaran actually enumerated all the presentations, but you will see that they are very vague. It is not very specific. It's low back pain, it's localized tenderness, it is reduced movements, and you can also present with a neurological deficit at a later stage. But it's no different from other lesions. Now, this actually illustrates very well. Now, this 54-year-old patient had a lot of pain in the neck, and he was diagnosed to have a lesion in the cervical spine. This is a late MRI, but the initial MRI showed a small lesion. And because he also had a pulmonary tuberculosis at the same time, it was thought to be a spinal tuberculosis. They did not go in for correct treatment, and then he presented to us with quadriplegia. So never assume anything unless you do a biopsy. You need to be very careful about it. The radiological features also is not very specific. Now, you can have a lot of cystic lesions like this. You can have a pathological fracture. You can have a compression of the bone. And you can have things which are very, very typical and common to other lesions, and there is nothing specific about a GCT in the radiological feature, especially in the spine. Also, don't rely on X-rays because it is a poor and late indicator. If you are talking about a symptomatology or a presentation at the cervicothoracic junction or in the sacrum, you will find that you are not able to diagnose this tumor till very late. Now, this patient, you can see that there is almost a translation of the spine. And this was not diagnosed because the higher level of imaging was delayed. This is the same. You can see that there is a sacral lesion here, not diagnosed for a long time. But when you take a CT and MRI, you can see that the horse has run out of the stable for too long a period of time. And what should have happened is that you should have done an imaging much earlier. Another case over here, a patient with low back pain, just neglected for higher imaging. And when the patient had the imaging after 8 months, you can see that the lesion had become too large. Now, the fourth principle is diagnosis and prognosis depends on histology and staging. So you need to have a good histology. That's fundamental. However much clinically or radiologically it is suggestive of a giant cell tumor, it is a giant cell tumor only when it is histologically proved. You don't do a fine needle aspiration biopsy for this. It always has to be a core tissue biopsy. So use a J needle, and you need to have a 3 or 4 passes, get good cores from the right site, and then you will make a good diagnosis. So the histology in a giant cell tumor is usually there are 3 cell types: the multinuclear giant cell, the spindle cells, and the round cells. Now, although it is called the giant cell, the prognosis doesn't come according to the large multinucleated giant cells, which are reactive. It is actually the smaller stromal cells and the behavior and the characteristics that they see under the histopathology, which actually gives us a clue whether it is neoplastic or not. Now, once you diagnose a giant cell, what are the options available? Now, as Devendra said, for long bones, the same principles apply for the spine. The best results come out of surgical clearance, and the prognosis depends upon how good your surgical clearance has been. Radiotherapy has only a very limited application. Now, this meta-analysis very clearly shows the fact. Now, if you look at 239 spinal lesions which were studied, you can see that the recurrence rates with radiation therapy alone is 49%. That means every alternate case is going to recur. Now, if you do an intra-lesional surgery, it's not much better, 47%. And if you do an intra-lesional excision with radiation therapy, not much better at all, 46%. If you need to do a good job, it has to be a surgery with wide margins. And to do that in the spine is a surgical challenge. And you also need to be sure of the other fact that radiation-induced sarcoma, it develops in 11% of patients when you are not completely excised and you subject the patient to radiotherapy. So if you have to do a good surgical job, you need to do an accurate localization and also staging of the disease. So you always look at curative therapy. And if you have to do a curative therapy, you need to understand the terminologies. Now, if you have a lesion like this is called intra-lesional. You go in and you take some bit of the bone, but it is not complete. Marginal is when you go up to the margins and little beyond into the normal tissue. This is wide excision. But if you need to do a radical excision, that means this we sometimes do in sacral tumors where we sacrifice even the dura and the nerve roots for giving benefit of a complete radical excision. In rest of the spine, it is usually a wide en bloc excision outside the pseudocapsule. To do this, you definitely need to have a preoperative embolization. There is a very good report from the Mayo Hospital where in the 1980s, before embolization was very common, 18 of 96 patients actually died in the perioperative or on the table because of severe bleeding. So if you have a lesion like this with such a prominent tumor blush, it's a very dangerous thing to do a surgery. You need to embolize. And when you see a picture like this, and if you're going to operate on this patient the next day, your mind is at rest. Another sacral lesion, you can see there is such a prominent tumor blush. You can see a lot of tumor vessels. And when you have actually completely embolized, it makes your surgery much safer and better. How do you decide what kind of surgery do you do? And for that, we utilize the WBB classification, where on a transverse section of the spine, it is divided into 12 quadrants like that of the face of a clock. Now, if only the posterior structures are involved, then a posterior resection is enough. Whereas if it crosses the midline, then you need a sagittal resection. And if it is in the front or if it comes behind, you either do a vertebral body resection, or most prominently, you can also do a complete vertebral excision. Now, posterior resection alone for a giant cell tumor is very rare because this location itself is very rare. But here you can find one patient where the vertebral body is normal. All that is involved is the posterior line. So that allowed us to actually go and do just a posterior resection. And this is the postoperative lesion that you see. Mostly, almost always, you'll find that the giant cell tumor involves the body and also involves the pedicle, either on both sides or on one side, which makes it mandatory to have a vertebral body resection. Now, there are two approaches to do a vertebral body resection. I'll just go into the principles, not going into the details. That which was proposed by Tomita, where you do an en bloc resection, everything from the posterior side, is most ideal but most challenging. So most of the people would now do a combined extra and intra-lesional excision of the tumor in two stages. From the posterior side, you excise all that you need to excise from the posterior side and also a large part of the pedicles. And then you also do a posterior fixation. And then either on the same day or immediately on a second stage, you can go and do a complete vertebral excision from the anterior side. Now, this is one of our favored approach because if you look here, this is the total en bloc spondylectomy, which was published by Tomita, which made him very famous in 1994. But this is the way that you do it. You are gone on the posterior side, you excise all the posterior structures, and then you do a costovertebrectomy approach on either side, and then you disconnect the vertebral bone, and right from the posterior side, you deliver the whole of this bone. Now, this is a slide from Boriani, and you can see that everything is done from the posterior side. But if you look at the blood loss, you will find that many of these patients have a blood loss of more than 5 liters, up to even 13 liters. Now, that is a serious risk, especially in our setup. So what we do is a two-stage approach, where in the first stage, you can see here that we have gone and completely excised the posterior structures. Between the nerve roots, we also remove the pedicles fully on both sides. So whatever is left behind is only that part of the body, which we can go anteriorly. And once the body is removed, we reconstruct it using a titanium cage filled with bone grafts or allografts or a rib graft. And then you can find that the whole vertebrectomy has been done and is also very well reconstructed. Now, this is a patient whom we did about 14 years ago, and he is completely normal. Another example for a two-staged approach, you can see that there is a typical giant cell tumor over here. Typical radiology and typical MRI pictures, CT shows that there is a complete destruction and the bone has started collapsing, and the same approach was performed. So this actually gives a very, very good results for us, very predictable, very safe, and without much blood loss. But what actually makes giant cell tumor difficult for surgery is when it occurs in junctional lesions. For example, if it happens at the L5. So you can see here, there is a, in 2013, there is a lesion in L5. This patient came to us referred for a disc prolapse because of low back pain, but actually radiology just showed that it is tumor. He had actually had surgery outside and he came back with recurrence. And you can see that there is a good progress of the tumor by then. And we just fixed on the first stage. You can see that there is a spinopelvic fixation because we have to excise the entire L5. And once this was done through a phalansteal approach, we went in, completely excised L5 and also reconstructed it with an expanding cage. Now, this patient had embolization and he had a very good result. This was his first year postoperative picture, but you can see after 6 years follow-up, everything is good. The CT scan shows a complete healing, no recurrence, and this is him after 6 years. Another place where you can have a challenge by the location is this patient who had a giant cell at C2 and C3. Now, impossible to approach this through transoral because it is below C2, and it is also not possible to go via the neck because it's much higher up to C2. The only way that you can have a good excision is to do by opening the mandible as a book. So you can see that we are going through the midline. In this approach, you actually split the lower lip and the chin, and then you do an osteotomy of the mandible. You can see that the mandible is being opened up like a book. And after that, you actually cut the tongue into two. The tongue is separated, and you can see over here that once the tongue is separated into two, you have an absolute approach on the soft palate. You can even dissect the soft palate if you want more approach, but in this case, it was not necessary. The entire retropharynx is completely in your vision, and then it is possible for you to completely excise the tumor and then reconstruct it with an expanding cage. And this is the actual reconstruction of this. Now, this patient had a symptom-free period for a few years, after which he had a recurrence, and then after a few years, he actually died. But you can see the reconstruction is back again. You can see that the tongue is being sutured back, and then the mandible is plated back. And this is him, and this was his 4-year follow-up, after which he developed a recurrence. So to end and conclude, I would come back to this slide, which I think is the most important slide of the whole presentation. That a surgeon should know that a giant cell tumor in the spine is the same tumor which can be very aggressive. And it is the same principle that surgery is an important but a small step in the overall management. You need to depend on your friends, your radiology friends, your pathology friends, and also your oncology person. Because diagnosis, staging, tissue diagnosis, preoperative embolization, your correct what you need to do for your adjuvant therapy, and how do you follow up. All this actually comes into how good you can do for this patient. So thank you very much, because this is a very exotic tumor which is occurring in an exotic place when you talk of spinal GCT. Thank you very much.